Welcome everyone to our April 2021 Health for Her seminar. We are very fortunate to have Dr. Pat Ocampo presenting to us today. My name is Mike Smith, and I'm pleased to welcome you on behalf of the Center for Applied Research and Evaluation in Women's Health here at East Tennessee State University. I'm going to give Dr. Ocampo a quick introduction and then turn it over to her for her presentation. So Dr. Ocampo is a professor of epidemiology at the Dalla Lana School of Public Health at the University of Toronto, where she is the Canada Research Chair in Population Health Intervention Research. Dr. Ocampo is an internationally renowned public health scholar who has an active research program that focuses on understanding the health impacts of complex urban social problems experienced by low-income populations. Through her scholarship over the past 25 years, dedicated partnership with affected communities, and academic leadership for over 15 years, she has generated strong evidence around interventions to improve the lives of those living with multiple health, social, and economic challenges. She has been widely recognized for her contributions to population well-being through the receipt of early, mid, and late career awards given by national and international organizations such as the U.S. Centers for Disease Control and Prevention, the American Academy of Pediatrics, the American Public Health Association, the U.S. Institute of Medicine, and she was most recently inducted into the Royal Society of Canada. Dr. Ocampo will talk to us today about the importance of focusing on social determinants of women's well-being in the design of policies and solutions to ensuring that we even the odds and close the gaps of inequity for women and girls, including longstanding racial gaps in health and well-being. Dr. Ocampo, thank you again for joining us, and take it away.
Thank you so much, Mike. And it's great to be here with everyone. Thank you so much for joining over your lunch hour. So as Mike mentioned, I want to talk about how we can use research to create a fairer society for the health of women and girls. You might wonder who I have here pictured on my title slide. I have a little project that I'm doing. You know, we have a lot of silhouettes of famous men that we can immediately recognize. So Mandela, Martin Luther King Jr., Che Guevara, even Abe Lincoln, but we rarely see silhouettes of women who have made great sacrifices, dedicated their lives to improving the world for people in general and for women and girls. So hopefully you can recognize one or two of them. And if we have time at the end, I'll reveal the identities of these women who we should be promoting more often because of their amazing contributions. I would like to begin with the Land Acknowledgement. As we gather today, we acknowledge the myriad traditional and sacred lands on which we are all sitting and standing. We are in two geographic locations which have been the sites of human activity, starting with indigenous peoples for 15,000 years. The land where I'm standing now is the traditional territory of the Huron-Wendat, Petun First Nations, Seneca, and most recently, Mississaugas of the Credit First Nation. I am grateful to have the opportunity to work in the community that we now call Toronto. I'm a visitor on these lands as my own Indigenous peoples are from the Hashiman Nation in the southwest corner of the United States where I was born. I had the opportunity to study the traditional lands where East Tennessee State University is located and learned that it was the traditional lands of the Muskogee, Yuchi, Chickasaw, Cherokee, Shawnee, and Seneca. I'm mindful of broken covenants on both sides of the US-Canada border and the need to strive to make right with all our relations. Today, before I tell you about the messages that I hope you will take away with you, I just want to call your attention to Poll Everywhere. And I'm hoping that sometime during the presentation, probably about halfway through, you can go to Poll Everywhere, and we can go through about 4 questions that we have there, or that I've created. So I just wanted to give you a heads up about going to Poll Everywhere, and Pat Ocampo 199 is what you'll be doing. You know, there is a text option, but I'm not sure it works very well, but I provided it there in case that's how you want to access them. But in terms of take-home messages, I'm hoping that you will learn that research on the social determinants of health will help create a fairer society for women and girls. And that each of the social determinants is complex and has a heterogeneous relationship with the populations of women that we tend to study. And no matter who we are, whether they're researchers or whether we're students or even funders, we each have a responsibility to sharpen our focus on the social determinants of health and also systemic oppression that acts as barriers to create a fairer world for women and girls. So I'd like to begin with the idea of women's health. And, you know, what comes to mind when we think about studying women's health? So you've been having these series for many months now, and you probably are very familiar with the kinds of topics that come up when we think about women's health, or the kinds of determinants that we should study when we think about women's health. I also forgot to mention that feel free to use the chat as a way to create dialogue. I will be monitoring as much as I can. So when I search for women's health issues, you know, I often come up with frameworks like this one that I'm going to share with you that comes from Ontario. This is a kind of an agenda, a focus on women's health issues that an organization here in Ontario has described. So we've got on the left, you know, the disease conditions, whether they're chronic conditions, sexual and reproductive health. Mental health is a very big issue when it comes to women's health, and during the pandemic, it's even receiving more attention. And then there's at the bottom some intersecting issues. You know, one great thing about this framework is that they care both about the life course or the age continuum, because issues are different across the life course, and also equity. I hope you can see that. So yeah, there we go. Equity is also on the right. But you know, there's a lot of focus on these disease conditions that we should be addressing. How about in my field, in epidemiology? When I look at how folks in epidemiology address women's health, here we have women's health epidemiology. And some of the terms that you come up, maybe understandably, are research methods like longitudinal, but also we have those disease or those life stage periods, midlife, menopause, chronological aging, disability, hormones. There's a lot of focus on physiological aspects of women's well-being. And so I keep finding that over and over again. What I'd like to argue is that we need to expand our focus on women's well-being, and not just focus on health conditions or some of the biological and physiological factors that are important in determining women's well-being, but that we should really focus on the social determinants of health. What I'm showing you here is the WHO Social Determinants of Health framework that came out in their landmark report in 2008, which demonstrated that there are population-based inequities in every single country in the world. Yes, it was a long time ago, but it was really important in putting the issue of health inequities on the agenda. And they created, the Commission on the Social Determinants of Health, created a framework to help explain how health inequities are created. And so while it certainly acknowledges the biologic, physiologic, and behavioral factors that we all think about when we think about women's health and population well-being, here in this sort of bucket of determinants on the right, the intermediary determinants, I would encourage us to not ignore those factors that are really the root causes, or what Sir Michael Marmot, who is the chair of the Commission on the Social Determinants of Health, calls the causes of the causes. Those root causes, the structural determinants of health inequities. And they're the root causes because they're really the policies, the social policies, the public policies, the values and the culture of a society, which contribute to the inequities. So that's this column here. I don't know if you can see my mouse. So class inequities, gender inequities, inequities by race and ethnicity, education, occupation, and income. And those in turn shape the behaviors and the psychosocial factors that create, that are the immediate determinants of population well-being and inequities. And so while we do focus on the social determinants of health, our research tends to focus on those intermediary determinants. If we were to look at all of our research in public health and epidemiology, we'd see that really a small proportion is focusing on those root causes, those structural determinants of health inequities. So in an ideal world, we would have a better balance, maybe half and half. And I'm not in any way saying that we should ignore those intermediary determinants. We do need to know about those, but we need to know more about these root causes. So if you don't believe me or trust my opinion, that's okay. But we can consider what some other experts have said. So I don't know if you know, or we haven't really said it yet, but today is actually World Health Day. April 7th is World Health Day. I don't know if you know what the theme is for today or this year, 2021. But in 2017, the theme was mental health. And I bring up mental health because mental health is such an important issue for women. Maybe you can think for a moment or look up what the theme is for 2021. And in the meantime, I'll tell you what the Special Rapporteur said about mental health and how we need to address mental health issues around the world. The Special Rapporteur in 2017 said the use of psychotropic medications as the first line treatment for depression and other conditions is quite simply unsupported by the evidence. The Special Rapporteur goes on to say we should not accept that medications and other biomedical interventions be commonly used to address issues which are closely related to social problems, unequal power relationships, violence, and other adversities that determine our social and emotional environment. There is a need to shift in investments in mental health from focusing on chemical imbalances to focusing on power imbalances and inequities. So even the Special Rapporteur to the UN said that we should be focusing on those upstream determinants. Okay, so that was mental health in 2017 for World Health Day. This year, the theme is, let's see, no one's weighed in on that. Together for a fairer, healthier world. I think that's appropriate, not only for this talk, but also for what we're seeing that is happening in with COVID around the world, not just with the infections, but with the mitigation strategies of the vaccine. We really need to be acting together for a fairer, healthier world. Okay, so just to summarize then, research from medicine and public health rely on biomedical frameworks, and that makes sense. In order for the medical community to do their work, they must rely on biomedical frameworks. But for public health, I think we could do a much better job of doing a better balance of looking at root causes as well as intermediary causes of population well-being. And if we don't look upstream, we may miss those root causes of inequities and suboptimal well-being. So research on solutions to creating a fairer world must consider not only the social determinants of health, but those structural determinants of health inequities. So in thinking further about those social determinants of health, this is another depiction by the Kaiser Family Health Foundation of the structural determinants of health. You know, this is another way of kind of maybe simplifying the way in which these social determinants of health are presented. They have them in nice categories, and they have single words, maybe a little less messy than that framework that I showed you. But you know, one concern I have about depicting the social determinants of health in this way is that it kind of gives the impression that these problems, you know, hunger, literacy, safety, are fairly straightforward and maybe simple to understand and solve. And I think that's a bit of a misrepresentation. Maybe we can use one example of the social determinants of health, housing, because we know how important housing is across North America. In every city, we're really facing a major housing affordability challenge. We can dig a little bit deeper just to show kind of the complex contours of the issue of housing, and especially how it affects women. So I want to call attention to Shaw's work, which talks about how important it is that we acknowledge the multiple dimensions of housing that affect health. I would argue that in our housing research in public health, we tend to focus on the two ends, so physical and financial, and maybe we ignore the two in the middle. When it comes to, and I'm not in any way suggesting that physical is not important. Physical is very important. Crowding, for example, a very relevant example for today, puts individuals at risk for increased risk of infectious disease. But there's even been studies showing that crowding impairs child development. Heat or cold or dampness, including poor ventilation and mold, leads to respiratory problems and allergies. It's been shown to lead to high cholesterol and high blood pressure. Indoor air can affect the possibility of poisonings. Think of secondhand smoke, for example. Cancer rates are higher in households with secondhand smoke, and so are respiratory problems. And then there's the structural issues where substandard structures can lead to injuries. Faulty appliances can lead to fires and burns from fires. So physical is absolutely important. But when it comes to looking at the full spectrum of issues, it may be that psychological is just as important, if not more important, but we tend to ignore the psychological. The psychological includes feelings of safety, building your identity, and something called ontological security. What is ontological security? Ontological security in a person's everyday life is where people feel in control of their environment, free from surveillance from others, free to be themselves and at ease in the deepest psychological sense, in a world that might be perceived as being threatening and uncontrollable. Sounds like we're in a situation like that now with the threat of COVID outside. And this ontological security, having a place where you can experience ontological security, is really important. So again, we might consult experts to say, okay, which of these is important? And maybe I'll put cost to the side, because we all know that cost is very, very important. But what about between physical, psychological, and locational? You know, real estate people, those who sell houses, will tell us what's important if you look at their ads. So let's look at a few of them. Here's the first one, and these were chosen somewhat at random. And when you look at these, what is being emphasized here? Probably not the physical housing, although you do see some of the housing that's there. I guess my conclusion is they are definitely emphasizing the psychological aspects of housing security. Here's the next one. Here too, they show you a picture of the building, but what's really prominent here is you will find peace of mind in these condos here at Edgemount. And so here, emphasis is on the psychological. And the last one, here we go. You're going to get a lot of status if you go to these Yorkville condos. So I think real estate agents are appealing to what's really important to people when it comes to housing. So we know cost is important, and I mentioned that. Increasingly, people in North America are spending a greater proportion on housing. These are very old data showing that 30% of people in the United States are spending more than 50% of their income on housing, and they're certainly leading other countries. And I think the situation has only gotten worse since these data have come out. Also, there's the problem of evictions, which seems to be getting more attention. Evictions have adverse negative consequences. Obviously, you become homeless, or it has a huge impact on psychological well-being. Women in national studies are slightly more likely than men to be evicted. But in public housing, there's a type of eviction called illegal act evictions. And that's if a crime is committed within that housing unit, then you can be evicted. And women are far more likely to be evicted from social and public housing, perhaps because they're more likely to be consumers of public housing. But sadly, 80% of those evictions are because of a crime committed by somebody who was not the leaseholder. So women are victims of these illegal act evictions, more likely than men. So when we think of the common ways in which, in public health at least, we ask about housing, we ask these questions: do you rent or do you own, and where do you live? And we usually use that information to assign some kind of area level indicator, or do you live alone or with others, or how many rooms in your house? Those really don't adequately capture all the 4 dimensions of housing security that I just mentioned. We need to do a much better job. But I guess the other thing that I want to emphasize when it comes to housing and women's well-being is that these housing issues are too often presented in a gender-blind fashion. And when we present issues in a gender-blind fashion, they always favor men's needs. So we can consider using some kind of a framework like a gender transformation continuum, where we acknowledge that there's a continuum between being gender blind, so just not even acknowledging that women or men may have unique needs, all the way up to gender transformative. And in the middle, we can at least acknowledge that women and men have different needs. And what if we did? Would we understand housing and those 4 dimensions of housing security in a different way? Well, let's see. So housing does impact women differently than it does men. And if we think about the physical dimension, we know that women are more likely to live in substandard or crowded housing. Why? It has to do with cost. We know that women make less money than men. Their wages are lower. ERA hasn't passed yet. They're more likely to be under or unemployed. More single mothers live in poverty, and social assistance doesn't cover all the household expenses. Women also have fewer choices about where to live. So women tend to experience discrimination by landlords, especially if they are single mothers or perhaps are fleeing from a violent relationship. And they also have a greater need to be closer to work. And closer to work, because they might have to rush home to take care of a sick child, pick a child up from school. So they can't have 2-hour commutes to and from work. And also, there are more women living in general without that ontological security that I had mentioned for a variety of reasons. For example, they might be living with a roof over their head, but if they're living in a relationship characterized by violence within their home, they won't have that ontological security. Now, these dimensions don't have to travel together. So if you don't have physical security, it's not guaranteed that you won't have the other kinds of securities, and that each one has its unique pattern. But these dynamic patterns of each of these features make it more challenging to find easy solutions to help women acquire all of these types of housing security. So each of these social determinants on this framework is just as complex as housing. And we could also benefit from approaching each of these with a gender transformative lens. And so if we, and I'm not suggesting this is the only gender framework that you have to apply. I'm just giving you an example of one which is helpful. So we want to really move from being gender blind, which ignores the unique needs of women, and maybe even going beyond gender sensitive to being gender transformative. So let me give you an example of what that might look like if we were to apply it to, say, a policy that is helpful in housing, and that's Section 8 housing subsidy. Section 8 housing subsidy keeps the costs of housing to 30% of your income. And the challenge is that once you're eligible for it, you have to use it within 4 months. But also once you apply, or once you're approved, you often have to wait months as well in order to get access. So there's a lot of waiting to actually get access. And when you finally get access, you've got to be able to find a place to live and get approval from the landlord and move all within 4 months. That's kind of a short window. If we were gender transformative in our approach to Section 8 housing, we would definitely lengthen that 2 to 4 month use it or lose it window. Because if you don't lose it within 4 months, you have to go to the end of the line again, and then you have to wait months and months, if not years. So we would probably give people a much longer period to find a place that they're satisfied with. We would also eliminate the wait list. So there's a wait list because the program is not fully funded. There's much more demand than coverage for this policy, which is true of a lot of social policies in the US. And then because we know there's a lot of discrimination of individuals who are on Section 8 housing, especially women, there would be a component to the policy to address and penalize landlord discrimination. So that would be a gender transformative approach to looking at Section 8 housing. Sadly, we don't have that. And so a lot more women lose out because of the characteristics of the policy than men do. So I can't neglect the fact that housing impacts racialized populations differently as well. So we know that racialized populations have experienced discrimination, employment discrimination, and they have lower wages and incomes. Mortgages, it's been demonstrated that mortgages are harder to secure for Blacks, especially Black women. They are particularly targeted for denying them mortgages. Homes in Black communities are not a source of wealth like they are in communities that are largely white. That is one source of wealth generation for so many Americans, but not for those who live in communities with high proportions of Blacks. In fact, those houses in those communities often lose value over time. Segregation still happens. It is improving, but probably too slowly. Resources in racialized communities are poor quality. Think the quality of schools, for example. Discrimination toward non-white renters and homeowners limit housing quality and also limit where individuals can live. And more racialized women are living without ontological security in the home. We talked a little bit about evictions before, and here I'm presenting to you data of eviction risk by level of education. And so for every level of education, Black households face the highest level of risk for eviction. So we've got the red bar here, which are Blacks, and we have other groups. And we can see that for every level of education, Blacks tend to have the highest risk of eviction. There was recently a study that came out that shows that if you have experienced or were at risk of eviction in the year prior to giving birth, you are at much higher risk of, or you're at increased risk of having adverse pregnancy outcomes like shortened gestational age and preterm birth. Even though there have been moratoriums on evictions during the COVID pandemic, and for many populations, eviction rates declined. So we have here from late May 2020 to early June 2020, we can see that that was not the case for Black populations. In fact, evictions of Black populations increased during this time. So I'd like you to think about why that might be happening. You know, this slide and the previous slide that I showed you is an example of how we demonstrate gaps by race or sometimes gender. It's important to do that because then we can flag that something is not right here. Something is not fair. But we can't just stop at demonstrating gaps. We really need to investigate the causes of these inequities and then move quickly toward designing effective solutions to eliminate those gaps, to create a fairer world. So we can't just keep demonstrating gaps. So thinking about these data that I showed you, do you have some thoughts about why there are gaps by race? If you do, maybe you can just put it in the chat. Anyone? So when we see these gaps by race, I would say 9 times out of 10, if not 10 times out of 10, the reason for those gaps is racial discrimination. So racial discrimination can be defined as an action or inaction made possible implicitly or explicitly by power relations. They could be individual level or types of discrimination. There could be institutional practices. You know, in the workplace, it could be hiring practices or it could be promotion practices. There could be societal policies and norms that affect what's happening. We'll talk about some examples of that in a bit. But so when I talked about needing to go beyond just demonstrating gaps, I was meaning that what we really need to do is we need to start unpacking the causes, and we need to measure what's happening, and we need to be thinking about and measuring racial discrimination. So, you know, if you look at the research literature, you can see that we are finally going beyond just demonstrating gaps when we're talking about racial inequities, and we are studying racial discrimination. So I did a quick PubMed search for the last 5 years or so, and you can see that the number of articles with racism in the title or the abstract is increasing. So starting with about little under 200 in 2015, and every year it keeps going up. Now, keep in mind for 2021, I imputed based on 3 months of data, and that's where we will be going if the latter part of the year looks anything like the first 3 months. So we're doing a pretty good job of going beyond just demonstrating gaps and starting to investigate the causes of those gaps. But we might not be going far enough, because something is also causing, there's some root causes of racial discrimination. And so we need to go, if we want to really understand what's causing it and how we begin to address it by looking at the root causes, we have to understand what are the societal attitudes and what are the societal beliefs that are contributing to continued racial discrimination, whether it's implicit or explicit. And we need to recognize that there's a system of oppression based on structural racism, settler colonialism, and white supremacy that is really keeping all of this in place. And we need to begin to study those as well, because those are the actual root causes of racial discrimination. Bond says that if racism and privilege are the symptoms, then white supremacy is the disease. And you know, we don't really talk about white supremacy. When we think about racial discrimination, we think that that's happening in racialized populations. And that we need to look there in order for us to really understand what's happening, or it's the problem of the people who are experiencing it. And we don't really have a complete picture of what's happening. But issues like white privilege and white supremacy kind of act as a barrier to any initiatives that we try and put in place. They push back on the initiatives that we try and put in place to eliminate racial discrimination. And so we need to acknowledge it so that we can begin to understand how to dismantle it. Again, here, how have the researchers been doing? We can take a quick look. So researchers, fortunately, are catching on. And so another PubMed search of articles by year in the last 5 years shows that there has been a focus, an increasing focus on the issue, on the topics of structural racism, and that's in red. So we've had going from 0 in 2015 to now in 2020, we have about 225 articles. And again, I did some imputation for 2021, and that number would be increasing if we continue on this path. And there's even been an increased focus on the topics of white privilege and also white supremacy. We can see by the green lines and the white lines. So researchers are beginning to try and understand these root causes, and hopefully we'll be able to develop some solutions to address these issues going forward more effectively. So maybe it's time to ask you what you think. If you could go to pollev.com, Pat Ocampo 199. There's 4 questions I think that I have asked for you to engage with, and we can go over some of what your feedback is. And I think one of the questions asked about the social determinants of health. So I will put up that framework again, so you get you're reminded of what some of the common social determinants of health are. So I'll give you a minute, take my sip of tea, and then we'll go to see what the polls say.
Pat, as people are logging on to Poll Everywhere and completing the poll, there was a question in the chat from Linda Nellums.
Yeah, thanks. Okay, I'm looking at that. Cultures are different. Rather than doctoring the elements of what you call inequity or racism, would it be possible that this condition is self-inflicted? I'm wondering if you're talking about the gaps. There are many successful race-identified populations. What makes some be unsuccessful? What are the root causes rather than housing? So you asked many questions here. I guess one way to think about whether it's self-inflicted is that what we're measuring is we're measuring attributes of individuals when we measure these racial gaps. And actually, the location of those root causes is upstream. In fact, a lot of it's not necessarily under individual control. We can't change society by just focusing on the individuals. And that's why it's very important to be looking upstream. We also have quite a bit of evidence that given the history of different populations and kind of the documented experiences historically, that those contributed to historical inequities. They were intentional, and sometimes they're continuing. So in Canada, for example, there has been a very long history of breaking up families and taking children away, whether it's requiring Indigenous families to send their children to residential schools, that is schools that are thousands of miles away from families from a very early age all the way through high school, to help them assimilate into white society and reject their own cultures. That happened for many years. The last residential school closed in the 1990s. There was also something called the 60s scoop, where children were again taken away from their families and then given up for adoption to non-Indigenous families. So those are colonial behaviors that began in the 1800s and or even before and continued through very recently. And so that history informs what their experiences are now. So I would say that the inequities that we see in Canada for Indigenous populations are definitely not self-inflicted. I see that a lot of people are doing the poll, so let's see if we can go to that. All right. Here we go. Okay. So the first question is, oops, let me just move this out of the way. Okay. My motivation to do my work. Okay, let's see. Here's the responses. There we go. Some people are doing their work because they're curious and they like research. And the majority of you really want your work to make a difference in the world. Thank you for that. All right, and next is regarding the social determinants of health and women's health and well-being. So none of you, either you're too polite to let me know that I haven't convinced you that social determinants are important, or I've made one or two interesting points about the social determinants of health, and many of you agree that we can't leave the social determinants out of our research on women's health. And here we are. This is beautiful. This is your word cloud about what social determinants you care about. So discrimination, education, cultural engagement, spaces, policy, exercising. I think this is beautiful. Thank you so much. Gender, literacy, this is excellent. Socioeconomic, fantastic. Oh, people are still contributing. Thank you very much. Maybe we'll go back at the end too, so that you can see what your word cloud looks like. Okay, and I think the last one was your, whoops, what happened? Okay, my next step in learning more about the role of social determinants of health, systemic racism, and women's well-being is research. Yay! constructed variables, questions, researching, listening, structural, literature, reading. That's great. Thank you very much. So maybe we can come back later and we can see how these have changed. I really, really appreciate your responses. So keep them coming and we'll go back. And in the meantime, I am going to share my other screen now and go back. I'll do a quick time check as well. All right. Ooh, 48. Okay, let's go. So does our research need to change? I think so. We need to focus more on the social determinants of health, like we said. And then maybe I'll just say that if we want to oversimplify research, we can kind of put it in two buckets. Problem focused, that is describing some of the problems that I told you about, even demonstrating gaps, or solution focused, evaluating potential solutions, doing evidence syntheses, tailoring programs so that they fit in a population. And here too, we have much more problem focused research than solution focused. So let's really move towards implementing solutions on the root causes. I'm celebrating the 10-year anniversary of my book because I've been writing a lot about let's move faster toward a science that informs and supports societal change. This book is challenging my field of social epidemiology to really think about solutions and do a little bit less of that problem description only. And I think I'm just trying to show you some of the programs that are happening around the US that have really dug in and started to look at some of those structural determinants of health. So we want to celebrate them. But I'm kind of curious, you told me through your word cloud about what some, about the importance of structural solutions and the ones that you care about. And I would say a lot of those are relevant for women's well-being. I created just a little collage here. And so we have like housing issues here, like the Fair Housing Act, making sure men and women are paid equally for the same job, paid a living wage. This is supposed to be childcare up here in the corner. So all of these, even though they're not related to healthcare, for example, are really important to support women's well-being. And I think you kind of got that from the talk earlier. Maybe I'll make a very small plug for this really innovative program at the bottom left here, where violence is a huge contributor to women's homelessness. When they decide to leave a relationship, they're immediately homeless and they have to go to shelters if there's room in the shelter, or they become homeless. Safe at Home is a new program that didn't really catch on in North America yet, but it is in other countries where instead of requiring the woman to move, she can stay supported in her home and the perpetrator has to leave. So her and her children's life is not as disrupted, and it's been shown to be safe in evaluation so far. So we need to adopt innovative solutions like that. You know, thinking again about those upstream determinants, we know that when there's more women in government, that they have different spending patterns of public money, and populations get healthier, not just women and girls. And so if we want healthier populations, we have to have a better balance of women in government versus men. But that is at risk because now all over the country, since November, there have been 250 bills introduced by the Republican Party across the USA to suppress voter rights. It was quite prominent in Georgia when Governor Kemp actually signed a bill in public behind closed doors and suppressing voting rights, limiting the hours that you can vote, limiting advanced voting. And so that is threatening the ability to put women and others in office, and that similar bills are being introduced around the country. But, you know, it's not all bad news. So we talked about segregation before. And I'm not sure if you've heard about what's been happening in Evanston. Not sure if you're familiar with redlining, but redlining is a way of denying individuals mortgages and money for housing and keeping segregation alive. Evanston in Illinois has owned up to their history of redlining going back to the 1860s. They've documented the ways in which redlining has affected the African American populations there, and they've determined the harms that have happened to multiple generations over time. And they've actually instituted the first set of reparations to African Americans because of their policies around redlining. And they're funding this with cannabis dollars. So this happened in late March, where there's reparations that are happening. And it would be great to evaluate how that is going to improve the lives of Evanstonians. So these are just some examples of structural factors that we should be looking at. And so I guess I'll end by asking you to think more, although you have already, and thank you for telling me what you are interested in, about which are the structural determinants of health inequities that you think we should be researching. If you're a funder, like what should funders be asking for? If you're a researcher, how can you design some research to be looking at this? All in the interest of improving inequities for women and girls and population well-being in general. So thank you very much, and I'm happy to answer any questions. How are we doing on time? Okay, we've got a little bit of time, a few minutes.
Yeah, we have a little bit of time. Thank you very much, Dr. Ocampo, for joining us and giving that very informative and enlightening presentation. I do encourage everybody that's on the line to ask questions. Let us know what you think. I've rarely met someone as acclaimed internationally as Dr. Ocampo is, and I've worked with her for a few years now, who is also as approachable as she is. So please, let's have some conversation.
So do I believe that politicalization of racism and race-related issues poses a large threat to future research efforts? I'm wondering if you're meaning like some of the backlash that was seen, for example, for HIV research because it had to do with sexual behaviors. I'm not sure if you're thinking about something like that. You know, what's interesting, and I didn't have time, so I didn't mention it, but NIH actually has a program called Unite. I don't know if you've heard of it, but Unite is about addressing structural racism in biomedical research, and they're funding projects which are evaluations of innovative initiatives to eliminate structural racism in research, like the research designs themselves, but also in workplaces, in research workplaces, in universities. So I urge you to look up Unite. It looks like NIH is embracing the goal of eliminating structural racism. I'm impressed. I know our Canadian equivalent to NIH hasn't done that yet, but hopefully we will follow suit. So I'm optimistic that the politicalization of racism and race-related issues will not compromise our research going forward. I'm going to keep my fingers crossed. And I think the program Unite gives us optimism that that won't happen.
Other thoughts or questions to share? Please feel free to unmute yourself and ask a question using your voice.
Thank you, Dr. Ocampo. Again, as you saw the comments, I mean, everyone that I've read the comments so far, very impressed with the presentation. Great presentation. Again, interesting, enlightening. So thank you for that. My question is, increasingly, we are witnessing, I guess, a widening in the divide, among population groups in terms of their thinking and approaches, to issues and attitudes, and increasingly we're witnessing, I guess, anger on both, sides of issues, driving, how we behave and how we think. And I know this is not an, easy question, but I would appreciate if you have any thoughts about how we can, have more calm, thoughtful discussions, to bring us together rather than anger.
Yeah. I guess there's potentially 100 answers to your questions, but I do want to call your attention to the fact that, while me personally, even though I'm affected by the pandemic and I have to stay home, I'm one of the lucky ones who can stay home. My job allows me to do that. There are many people who, even before the pandemic, were suffering every day. And I'm not sure it's that easy to stay calm when you're suffering every day and your children are, experiencing food insecurity. It's an issue that I think creates very big emotions. And so maybe we can't approach it calmly, but what we can do is find commonality with others. So for example, there's the Poor People's Campaign. Have you heard about the Poor People's Campaign that's happening around the country? It's not about any one single group. It is bringing all poor people, no matter gender, no matter race, together to fight poverty, to bring the right legislation and put it in place to ensure that nobody is poor going forward. They are united and able to visualize kind of a common threat and a common challenge. And so if we could have more of that, envisioning what your common challenges are, these are political issues. Legislators are in some states depriving people of rights and of opportunities to experience redistributed wealth. And so I think they are not issues that we can always approach calmly. But what we can do is see commonalities across people and not let false divisions stand in the way.
Thank you.
We are at the top of the hour, so if you need to jump off to head to something else, please do so. We will wrap this up very soon, but I wanted to open it up to if there are any last questions that anyone would like to ask.
And I promised to tell you who those women were.
That's right.
Okay, so I need to do that. Let's see. All right. So, oh, and my battery is running low. Let's hope I don't drop off because I don't know where my cord is. All right, here we go. Okay, so Harriet Tubman, I think you know that she was an Underground Railroad strategist. We've got Mother Jones. Again, she was a labor organizer and she helped struggle for the 8-hour day. Lucy, she was a labor organizer. Lucy Parsons, who's the next individual, she helped labor organizer and helped to struggle for the 8-hour day. And she really noted how while all workers are struggling for their rights, women are exploited more ruthlessly than men. Marie Equi, she was also a labor organizer. She was openly lesbian. She also attended medical school and was a very early safe abortion provider, very outspoken. And a quote from her is, "I'm going to speak when and where I wish. No man is going to stop me." Lolita Lebron, she's a political dissident working tirelessly her whole life, including being imprisoned for part of it, for Puerto Rican liberation. We have Anna Mae Aquash. She's a prominent member of the American Indian movement in the 1970s. Her activism may have led to her death by the FBI. And her quote is, "The whole country changed with a handful of raggedy-ass pilgrims that came over here in the 1500s. And it can take a handful of raggedy-ass Indians to do the same, and I intend to be one of those raggedy-ass Indians." We've got Angela Davis, who's an African-American activist. She's fighting against the prison industrial complex. And finally, we have Sylvia Rivera. She's a transgender activist, experienced a lot of discrimination over her lifetime because she is transgender, including being homeless. And she established the first organization to help transgender homeless youth in New York City. All right, so you have some people, some women in particular, who fought their whole lives. I hope you can look up more about what their accomplishments are and promote them to your colleagues and your friends. Thank you very much, and thank you for your time.
Wonderful. Thank you
for
again.
inviting me.
Yes, thank you again for joining us, Dr. Ocampo.